Good afternoon or good morning, depending on what part of the country you're in. We are so excited to have you all here for this conversation on building responsive systems to care for folks in our communities. Before we get started on the content, I think we just wanted to call attention to, we're going to be talking today a lot about the people that are doing the work, ways to fix the systems behind the work, ways to talk technology and data and all of these metrics. We want to start with just like centering the people that this work is focused on, the people in our communities, the people that are on the streets in crisis, who the folks on this call, and I think many people in the audience here spend every day and their careers committed to finding ways to get better support their needs, better support the needs of the community, keeping them safe, keeping the community safe. And so those are the people we're here today to be in service of. And the goal in this conversation is to make sure that we can have a conversation that moves the movement forward, moves the organizations and the efforts forward that are trying to find new ways in our communities to support our neighbors. So we're really excited to be a part of that conversation here at Peregrine. Again, just introduce myself. My name is Tim Schreiber from the Peregrine Technologies team. We're really privileged to get to be a part of this conversation and be in this conversation with such great people like the panelists we have today. I think the reason, we're having this conversation and the reason we have, the folks here we have today is that we live in this really exciting moment. This really exciting moment where there are burgeoning, innovative new ways of responding to and supporting people in crisis in our communities. And that looks like different forms of first responders, a diversifying set of support and systems. All this innovation is also creating the challenges. What does it look like to go from kind of a traditional first responder ecosystem of firefighters and EMS and law enforcement to a much more diverse set of responders, alternative responders, behavioral clinicians, co-responders, different types of mental health and crisis response. And with this burgeoning set of new ways of responding and supporting our community, what does it look like for this system to work together? What does it look like for this ecosystem to collaborate in the most effective way? And I think that that set of challenges and questions that is rising in this moment is what's really exciting about this conversation today. And I think, the people you'll be hearing from today are some of the people on the front lines of answering those questions. So we're really grateful. We're really grateful for the group we have today. And so with that, I'm going to invite our panelists to actually introduce themselves rather than reading out their bios to you. You can go and read that online. But I want to just go around the horn and invite our three panelists to introduce themselves, their role in integrating these variety of ways of serving people with public safety, this intersection of human services and public health with public safety, and just a brief anecdote of why you do this work. What makes you passionate about this work? Because I do think, most of the people that are here today are probably coming because they're passionate about this work. They care about this work. And it's always great to hear, I think, from folks of like, what keeps you fired up? What gets you up in the morning? So with that, we're really lucky to have a diversity of folks here today. We have Captain James Nakayama, who comes from the law enforcement perspective. We have Drew Grabham, who comes from the civilian and response perspective. And then we have Dr. Amy Barden, who sits at the center of those worlds at 911 at where those worlds intersect. So we'll get to hear from all those perspectives today. But with that, I want to invite Drew Grabham. Please introduce yourself and give us a sense of what makes you passionate and gets you out of bed every morning to work on this issue.
Yeah, thank you. My name's Drew Grabham. I use he, him as pronouns. I have the lovely job of being our director of our street outreach services for a very large homeless services provider in Portland, Oregon called Central City Concern. My job is to create teams that are out on the streets delivering behavioral health care at camps, in the shelters, and connecting people to care. And so the intersectionality of the work with alternative responses is vital to this team's work, to be able to have handoffs to them and handoffs back to them. And what keeps me up at night is the solid stories of having solid relationships with folks sometimes for 10 years on the streets and seeing them succeed, and then sometimes being able to hire them on as peers. So seeing when we create a system that actually is person-centered and has good handoffs, people do get on pathways in their lives and then come join us to be a part of a community response. And that is always a lovely space to be in.
Thank you so much, Drew. Captain Nakayama, tell us about where you sit in this ecosystem and what gets you out of bed in the morning to work on these issues.
Hey, good morning, and thanks for having us today, Tim. James Nakayama, Concord Police Department, over in the San Francisco Bay Area in the county of Contra Costa. And just for a little context, Concord is a city of about 130,000 people, 30 square miles. We're the largest city within our county. Our county has about 1.1 million people. I am currently in a role in administrative services, investigations, but previously the last 5 years worked in field operations. One of the programs that I actually, probably one of the highlights of my career is working with our county program, and it's a recently started program called A3, Anyone, Anywhere, Anytime, and it is a revolutionary mental health field service that partners with the EMS system, law enforcement within Contra Costa, to bring mental health resources out in the field to folks that need it. So just as an anecdote, as a young patrol officer 20 some odd years ago, I would have to respond to mental health related calls, individuals in crisis, problems, fights, disputes. And, after we would debrief these events, is there a better way to do this? And interesting, my wife actually is a social worker, mental health clinician. She's a therapist, still practices. And we've had these discussions over the years. Isn't there a better way? And I'm happy to say in Contra Costa, we do now.
That's terrific. Thank you, Captain Nakayama. Dr. Amy Barden, tell us about where you sit in the middle of all this world. And again, what makes you passionate about this issue that we're talking about today?
Yeah, I run Seattle's third public safety department, which is called CARE. It's Community Assisted Response and Engagement. It was a reaction related to 2020, 2021, and also a reaction to escalating violent crime in the city. I house Seattle 911, the department, which fields about 900,000 calls a year for service. And so I'm not from this world. I'm from the nonprofit sector. And, my point of origin, my perspective is informed by those calls. So if you listen to the calls coming in, they're generally public health calls. Our top causes of death are suicide and overdose. And so very quickly, I realized we need a different kind of first responder. They need to be positioned as first responders and be integrated in the CAD RMS, work alongside law enforcement. We often go out in tandem with. Sometimes we go out with the fire department, EMS, mobile integrated health. But my contention is if we get that first response correct, and then build out a system that is actually rehabilitative, whether it's the coercive system of corrections, if it were corrective and rehabilitative, or if we had an appropriate behavioral health system to refer people to, that's when our cities will start to heal. So I'm very passionate about the work. I care deeply about people, and I can see that we fail people by design. I reject the notion that homeless response should be siloed from first response, which should be siloed from mental health, and medical is different. I think that's just wrong, that we should be really person-centered. And so I'm a big fan of Peregrine because I see that as a data solution to be able to pull together my CJIS protected information and HIPAA protected information. See how I did that, Tim? I can't help myself. Already the Peregrine plug.
Thank you, Dr. Barden. Well, before we go on, I want to also welcome Josh from the Civic Roundtable, who's co-hosting this webinar with us today. So Josh, I want to throw the mic to you to introduce yourself as well as the Civic Roundtable.
Yeah, absolutely. I'll keep this quick. Pleasure to be here. We're incredibly excited to be co-hosting this really important conversation. Just a bit about Civic Roundtable, because I know we're a little newer on the scene. We're a government operations platform with the mission of breaking down silos. So our goal is how do you equip those on the front lines with key information when they need it most? A little bit about my background, used to work a ton in public safety. And so know those first 24 hours are critical, but then how do you spend the next time when you meet these people? What policies, what can we learn from each other? So honored to be here today. We know this is an incredibly important conversation and maybe just the first of many we'll have on the topic, and would love to, be in touch and hear how this goes. So thanks so much.
Thanks so much, Josh. So before we jump into the discussion, we're going to put a few polls up that are just launching in this moment, just to get everyone who's here a bit engaged. We want to hear from you all. I'm curious to hear from you all. Again, the questions we're going to ask are three. When your community receives a behavioral health crisis call, what typically happens? When your community receives a call related to an unhoused individual, what typically happens? And what is your role within your organization? I think we'd love to better understand kind of what's going on in your community on these topics that, we've got these three experts here to talk about. And how do you play into that? Please just take a moment to respond there. And We look forward to hearing from you. Let's see. It sounds like we're already getting some votes or some responses on this first question, and looks like a pretty kind of fair combination of law enforcement response, health or alternative response led, and some co-response. On the similarly on the unhoused front, sounds like it's like a relatively similar situation. We're seeing about a 50-50 split here across communities. And looks like most of our folks here are coming out of the Health and Human Services world, at least the people that have voted first. Maybe that's just the Health and Human Services people are quicker votes. But yeah, thank you for responding, and please continue to take a moment to respond there. I think this is it's a good start, because I think what today's conversation is about is this balance between these worlds. How do we get the right response to the right person at the right moment? And sometimes it's law enforcement, sometimes it's behavioral or health led, and sometimes it's both. Like we really need both. And I think that is the challenge of this moment with all these new resources coming online in so many cities, is like, how do we get that right combination of resources to keep both responders and our neighbors safe on the streets. So with that in mind, Dr. Barden, you said something that just struck me that I wrote down. Like we're failing people by design, and I think this is something that's come up in our conversations. This group of like we do. I think a lot of people feel like there's a ton of resources, there's a ton of effort going into supporting the unhoused and responding to behavioral health. This has been a big topic of conversation, especially the last 5 years. It's been on fire in so many political environments. But I think a lot of people still feel like we're not cutting it, right? Like we're not having an impact on the problem. And so we'd love to hear from each of you, like what is it that's standing in the way of progress, or maybe even like perceptions of that progress, because we know those two things aren't always the same. So, where are we falling short despite this investment, and so we can better understand the problem. So, Dr. Barden, you want to kick us off just because you kind of inspired it with your comment?
Yeah, I mean, one of the most simple myths out there is this idea that there are people who just do crimes and they're mentally well, there's no behavioral health issue, they just do crimes. And so you've got a criminal bucket in 911 and those people belong in corrections. And then you've got people who struggle with mental illness and they don't do crimes. We have this idea that there's all these very specific tidy buckets of people who are out on our streets. It's just not right. It's just not right. There is always a mental health or behavioral health aspect if somebody is engaged in really antisocial behavior, right? If they're self-destructing or causing harm to community. And so we've got to start there. We've got to just reject the notion that there isn't always a mental health aspect. And so if you acknowledge that, then it would follow that you would set up a different type of team, a different type of response. That's the first thing. And then I think the other myth I'm always railing against is that, no, people just want to live in tents. They just want to be outside. Everyone's service resistant. This is a lifestyle choice. That is wrong. That is, I studied the brain. That is not how the brain works at all. But it is true that sometimes it is perceived to be a preferable way of being, right? For whatever reason, this feels better than the alternative I'm being offered by a stranger. And so I see Drew nodding. We should probably hand off to him now because this is his jam. But I think we just really need to believe that people can change, that their lives have value, and that we need to design a system that is centering that person.
I love it, because I would 100% agree. Like the level of complexity of someone on the streets needs is far beyond what we've even been able to measure. And having done this on the streets of downtown Portland for years, everyone would like things to be different in their lives. But what our usual response is here's a list of places you should go do it. Good luck. Right. And moving on. Right. And what I can share is everyone that I've worked with has trauma and has tried to access our services, and our services are absolutely unavailable to them. So I think one of the big systems things we have is we don't have shared visions or goals of what are we trying to accomplish and how can we truly work together. And how do I know what you're doing and what we're doing? So the system by design is absolutely right. It is fragmented by funding and other sources. But when we sit down together as a community of police officers, outreach workers, we all have the shared goal of let's have the right person go there. We just don't have the technology And sometimes the pathways to understand it, but the more we get to know each other, the smoother we are, the more effective we are with getting people on that pathway that they want to be on in life. No one wants to have be in crisis and have that be their response. They all feel shame and guilt when they have that. So let's have a different response for them to do it. And let's recognize that our first responders are also feeling traumatized. They're the ones representing a system that comes and says, I know you have all these needs, but I can only fix this. So if we're going to talk about wellness of our staff, we really have to acknowledge we have to redesign this system and take care of both the providers and the participants together. And I think that's very accomplishable if we actually agree to those things and we lean in together as a community response, and we don't let infighting happen of this is your person to deal with. These are our humans. People who are homeless are our community members. They come from there. They don't really come. The majority of them lived in Portland here, wherever it is. Like, they know what's familiar. So this is just a part of our call to take care of our community together.
Yeah.
In that section, I guess in that topic of like where we're falling short, yes, there are areas where we're falling short, but I also see us, failing forward in a lot of ways. And then one of the areas I see it is communication and actual genuine partnerships and a shared understanding of where we want to be as far as providing services. On the streets of Concord, we have probably about 115,000 calls to service that, our officers go to throughout the year. So it's quite a few. And out of those, how many of those are actually, can we say, are mental health related issues? Well, we have a portion of them, but then you anecdotally look at what are the mental health related issues, what are the unsheltered, unhoused issues, what are the things that are, combined with, drug abuse and alcohol abuse, and where all three of those things intersect. And it's probably upwards of, a third, maybe 40%, maybe more of these individuals. And what I can say is in the past, we've had, siloed programs, we've had siloed data. One thing that we're working on and we've had a lot of strides with is the communication and genuine partnerships between county resources and also our nonprofits, so we can communicate, meet in the middle, and identify, what our end state is, what our goal is. So that's one of the things where, yes, we have fallen short, but I see us, continuing to get better with that.
Yeah. So Captain Nagiyama, to build on that, like from your perspective, from the successes you've seen, obviously you guys have had some great successes in Concord, as well as the way in which you're kind of failing forward. Like, what would you say from a law enforcement perspective is the role of law enforcement in these crisis moments, but also in this kind of like ecosystem of responding to these crises?
Yeah, I think there's like a law enforcement aspect, but then there's a policing, and policing is really a more holistic idea, right? It's a more holistic philosophy of how do we provide safety to our community? How do we resolve disturbances? How do we meet people and understand and provide understanding between the city government, county government, and also individuals that may have conflict? One of the things that we are working on within Contra Costa County, and this started with a local tragedy with the city just south of us. They had a mental health related call for service, resulted in the death of the individual who was being contacted. And it spurred this really larger conversation in the 2018, 19, 2020 timeframe. And through leadership at the county level, through the county behavioral health system, and also with the city managers within Contra Costa, they came together to find a better way. And it took the buy-in of that leadership team, but also at the law enforcement level and within the county and the behavioral health system. And they eventually, built a committee, a group to identify and build this new program. And that's the program that, that we're a part of. And, we're proud to be a part of it to divert these calls to service. It's the A3 program in Contra Costa, and it's about call diversion. And I explain all this to say it's about getting the right resources to the people at the right time. And that's really the fact of the matter. Law enforcement has been burdened with, being the frontline first responders, and it's really by no fault of their own, 24 hours a day, 7 days a week, from the officers working the streets to our dispatchers working in our communication centers. There's really nobody else traditionally that is working those hours. And when somebody is having a problem, when there's an emergency, that is the place that people call 911, and it's who goes. It's the police officers, maybe the firefighters that go, the EMS, but there wasn't that fourth system, and we have that fourth system here in Contra Costa. It's wonderful to hear with Dr. Barton that's something that's within her area of leadership. It is so important to get those right resources to folks when they need them.
So thank you, Captain. So Drew, tell me about, from your perspective as part of, was one of these fourth responders from the nonprofit, sometimes it's nonprofit, sometimes it's government run, but tell me about what it's, how you have found the right ways to collaborate with, work with law enforcement, which is the predominant response in most cities. It's certainly historically, and even to this day. Like, tell me about that dynamic and how you've tackled it.
Yeah, and I just want to give a shout out. Like, we in Portland are fortunate to have Portland Street Response, so we have our alternative response, and I partner with them on a regular basis. And really, how this started, PSR has only been here for about 5 years or so, but it started with just, we kind of got together and we started sharing and noticing. Being on the streets, we noticed the police were coming, and what we did is just work on that relationship. I absolutely need the police when there's like violence or things happening with folks, just like they would need us when they needed us to come and say like, oh, I know them, how can we do this differently? So we found some shared understandings about where we wanted to work together, and found those other ways to like really partner and see each other, right? Sometimes outreach workers and police don't always see each other as like partners, but we absolutely are when we know each other. So it's about getting to know each other and finding out how we can truly work together to do that. And one of our challenges is we don't have that system of care. It's like, who do you know? Oh, Drew, like right? And what we're trying to do here in Portland is like elevate this up. Like, everyone wants to know about that. And I have to navigate like 5 different data systems with our outreach team to figure out who they work with, which is like ultra challenging, and one of the factors that makes the job so hard and so frustrating for our staff and folks to do so. And I just keep saying, like, when we started to find ways that we could even collect data and share data, like, what is success? Success to me is we're saving lives. Success to me is we had a great overdose response. And success to me is people are actually starting to engage in the services we offer them. So we had to even come to like, are those what we're all working on? Great. Let's start to measure that and see how we can make those things a reality, and our goals that we share together. So I know my teams know how to talk about the police and vice versa. Our Portland Street Response knows that they can respond to the crisis. Then they can hand off when the folks are stabilized, and our team will welcome them. And folks can almost see us as one team, even though we're multiple agencies. And that's what's so lovely. I love nothing more than a co-visit with the officer or PSR on the street with somebody to show them like, hey, we're all showing up for you. What would you like this to look like? What can we do for you? And when we see that healing happen and that light switch change, then we start to see that traction happen of what we want to do is not have those 911 calls for those behavioral things. We want it for the other calls. And we start to see traction going on with people's lives. There's lots of people we've worked with that had 300 911 calls in a year. As we started to show up, we just saw that go down to 2 or 3, right? Or whatever it is. And then same thing, we looked at hospital visits. And then we started to pull in the cost savings. And what I just wanted to say, the data that we shared through, we've been able to share our HMIS data with some of our health share data. And we're seeing there's 8% of our population here in Portland that have either methamphetamine use, psychosis, and opioid use as their primary driver for like utilization in the ER. And they have like 40% of the costs. That's a very ineffective way. We have to figure out how to refund those funds to be actually proactive and not reactive. And so as we started to share data, find ways to like share our goals, we actually started to build more of an infrastructure. And I'll be super excited to share like Portland Street Response here just expanded their hours. Like, we're seeing that growth, and I just celebrate that tremendously. They're adapting, and they are a huge part of what my team needs. And I know that we're a part of their team needs.
That's terrific. There's so many threads to pull there. I think I want to come back to a few things you said, but I think just on this, I want to come to you, Amy, on the law enforcement kind of civilian collaboration here, because I do think a lot of people who are outside the space, I'll say this as someone myself who is outside the space, like, expect these groups not to work well together, just given the political nature of public safety in our country. Like, expect these groups are going to be at each other's throats. But I think more of these conversations I'm a part of, like, I hear more of what Drew and Captain Nakayama said about like the criticality of kind of working hand in hand. So tell us a little about what that has looked like, of like building that collaboration, and what has to happen like relationally. Like, Drew, I hear you talking about being able to see each other, but there's also stuff, Dr. Barton, that I know you've thought about like structurally, like how we organize ourselves that like enable that to happen well. So tell us a little bit about that in Seattle.
Yeah, I love the question. I mean, first I'll say to Drew's point, I actually went down to Portland to testify for Portland Street Response twice. And it was really interesting to be before that council because I recognize there is this myth that if we invest in this team, that is antagonistic toward law enforcement. So it was really fun to show up and say, no, it's not. Law enforcement advocates fiercely for this. They know where they're useful. They want to do the work that only they can do. They understand that by design, that is my coercive team, right? Those are my interventionists, but I'd like to exhaust diversion first. And I believe there's been a broad shift in sentiment across the country that people understand how imperative law enforcement is, and then also how imperative something other than law enforcement is as it relates to these calls. I have deep respect I never knew anything about CIT training, right? And so it was interesting through the 911 lens, and I go out on ride-alongs all the time. I work primarily in West Precinct. I had no idea how upskilled these officers were. And I learned quickly that they are expert at human behavior. It's just a different kind of expert, right, than my clinical social work friends. And so in really well-funded cities, I find that the units are growing relative to the data, and that's how it should be. Seattle, we have, as you know, fentanyl is pandemic level here. My first year on the job, we lost 1,400 neighbors to overdose. Half of those folks were under the age of 40. And we weren't really treating that like an emergency. We were talking about the homicide record, right, which was 73 that year. And so that's what I'm always advocating for, is just center the 911 data. Electeds need to look pragmatically at that data and then make sure that they're funding the unit to best respond to whatever those calls for service are. 5 years from now, it might not be fentanyl, right? It might be something else. And so if we can, regardless of the design, I like Atlanta model, you're outsourcing to nonprofits, right? That's what Denver's doing as well. That's cool. I'm pretty agnostic about how we design as long as the data gets integrated. Because in a perfect world, the 911 dispatcher would know something. If this person is mixed up in the system routinely, they would know, right? I can see, there were 4 overdoses, in the last 3 months. And so then that might precipitate a different response. Somebody's been arrested multiple times. The lead contracts, diversion contracts are moving to my oversight. And I'm really excited about that because basically I want to know if we're getting the intervention right. If an officer handed off to this diversion team for case management, and I can see that person is doing more crimes than ever a year from now, we're getting it wrong, right? So don't escalate commitment to that. I want us to be more scientific. Think about it as a course of treatment like you would for cancer. That intervention is not working. We're going to try something else. We're going to analyze what is failing.
Yeah, so I mean, both of you have mentioned, this challenge of data integration, and obviously we at Peregrine, that's what we do. We think all day about how do we, help state, city, county governments, integrate, model data to make it useful across, when it comes from lots of different places, when it's fragmented and messy and that's what we kind of spend our days thinking about. So I'd love to better understand what that kind of looks like in your space. And, Captain Nakayama, coming back to you, I'd love to hear about how you've thought about, you leveraging the law enforcement data you have, but also collaborating with the A3 team. And what has data sharing and integration across that divide looked like? And how have you tackled that issue of there's CGIS data over here, there's HIPAA data over here, there's CAD data in between? How have you tackled that in Concord?
Tim, that's a great question. As I'm listening to Dr. Barton, Drew, I have a lot of thoughts going through my head. And part of it is, thinking about what we do here at our police department, how our communications center receives those calls, how we categorize them, in our CAD system, our computer-aided dispatch system. But then we have to look at, our organization and this partner that we're working with, A3, and what they're calling their call center, what they're defining as a level 1 response. And for our county, a level 1 response is a peer support specialist, contacts the individual, could be over the phone. Level 2 response is it's an urgent, more acute type response, more of a serious crisis issue where a behavioral health clinician may go out in the field and contact that individual. And a level 3 is an emergency response. So it's something where law enforcement is going to be responding in a co-responder model, with a clinician out in the field, and we're going to respond to this event together and partner to find a resolution. That's the general framework of how A3 functions. Now, when that call comes into our 911 call center, we receive the call, we're listening to it, and we'll screen. If there's an immediate public safety emergency or a crime in progress, the officers are going to go. It doesn't mean that we're not going to request A3 to come out, because there may be a component where once the law enforcement function is resolved or stabilized, maybe we can bring in our A3 team to co-respond to try to de-escalate the situation, and we can kind of pivot, from that law enforcement function, the policing function, to, hey, how do we get this individual to the services that they need, or utilize that service to kind of bring peace and resolution. As we do that, we're constantly looking at how do we identify that these systems are working, that they're effective. When we have different terminology of level 1, 2, and 3, then we have what we call a 5150. In California, it's a mental health hold. We have a incorrigible juvenile. We have a 415, which is a disturbance. We have all these different terms, and how do we bring those two siloed data sets together? And really a plug to Peregrine, and then also Mark 43 is having data systems, your CAD and RMS, that are flexible and adaptable. So for us, when we do receive those calls, and if we do divert the call, or if it's a co-response, we're able to tag and label those calls as they come in. We have predefined sets of what is mental health related, so we can, over a period of time, track and see call reductions. We can identify the areas that the locations where those calls are coming in, and have data that supports these reductions of calls to service over a period of time.
Yeah, that's incredibly helpful. I mean, I think Drew, I'm curious from your perspective. You sit in the nonprofit space. Like, what does this look like from your perspective in terms of sharing amongst nonprofits, sharing between nonprofits and the government? Like, how does that work in Portland?
It's super complex, right?
Or not.
And
Or how does it not work?
Yeah, I think one of the things I've had to do is map out, any meeting I'm in, I'm like, where do you chart, and what data are you collecting? And I get to sit at those tables to understand that world. And what we've been trying to do locally is find different tools. One, have shared definitions, and then different tools that could actually connect. Thankfully, most of my work is either done in HMIS or Ocean and Epic. So it's actually pretty interoperable. So I'm always trying to figure out, how can we share data? There are tools to push the data and figure out that care coordination thing. And I know there was a question, some of this is we just had to have the right leaders in the city and the county and our health departments say, yes, we're going to do this. Now there's a line with what's shared with 42 CFR, but I'm on the street and I know our Christian friends, they just want to who are you working with, and how could I contact them? Really basic information, and then we start to have the right folks to call. So we have not I don't think we've figured it out yet. We are still building it as we go, but what I at least know that map, and it's so complex, it's I have to know what is image trend, I have to know all the different things to know who the people are. But we're getting better about elevating up, they're working with Drew, call them here, great. That's where technology could really make this much more effective for our systems and for our participants. So the more that we can even just share that, the better off we are. But James nailed it with we have to have the shared definitions. What does that even mean? We're even just trying to start there. What does outreach mean to you? And outreach to me means I'm on the street, I'll visit you at the tent. It doesn't mean I'm going to give you a phone call. But we had to even start with just that shared understanding. Then we sort of knew how to deploy the right services with folks. So it started with meetings, but from there we have more and more kind of collaborations, and we have weekly meetings in zones in our communities, in the downtown area. There's a bunch of us that meet together and just talk about trends. Are we seeing more overdoses, right? We're doing it tick marks and notes, and there's a better way to be more efficient in this, but until we have that, that's how we've sort of gotten this commitment to sort of continue to meet together as a community response.
To build on that, Drew, I mean, something, Amy, you and I have talked about previously, and I think we talk about HIPAA data, we talk about CGIS data, and I think one of the biggest challenges from a data governance perspective is how could we have those in an environment where they're both properly protected, but the data that can be shared gets shared. And Drew, you just mentioned we just need to know who they're working with. That's not sensitive patient data, that's not criminal history data, and being able to kind of separate between those and create the trust where that's possible. How are you thinking about that in, Amy, in terms of, figuring out that data governance and who needs to see what and how you control for that?
Yeah, so my urgent priority has been to pull together the data from the police co-response team, which is, again, a clinician in a ballistic vest going out with law enforcement. And then we've got a fabulous mobile integrated health team in the fire department that is our primary overdose response unit. Health One, Health 99. I was actually out riding with those folks yesterday. And it was interesting. I'm positioned in the middle, right? I've got the paired clinicians going out to calls. I'm CJIS backgrounded. We all are in care. So it was easy for me to be plugged into, not just the police CAD and RMS, but all of their data and analytics systems. I'm there. But then I also recognize I've got a foot in this human services world. And I recognize that you're all interacting with the same folks all the time, but you don't even know each other by design. And again, they're really nice collaborative people. They're just running and gunning and, trying to save their neighbors all the time. And they're just not designed to work together. And so we acknowledge right away, we need to treat these three different divisions, the co-responder units and then care, as three divisions of one team. And to Drew's point, we do the same thing, this high utilizer work group. And he said something crucial. The most imperative piece of information is who knows the person best, who has a stronger relationship. And we shouldn't make assumptions just because this person's in mental health crisis. It doesn't mean a care responder knows them the best. Very often, no, it's actually a cop who has a really, really solid relationship with this person and can get to yes, can get to a consent-based solution the best. And so if you at least can query that and pull it up real quick, what we've been doing to this point prior to Peregrine, it's just been analog, right? It's just us talking through these different cases all the time. People will call me, have you seen Michael? Is he in the hospital? So then I'm calling the hospital, and it's just ridiculous in this day and age in a city like Seattle that I'm using, an Excel spreadsheet. Not to knock Microsoft, but we can do better.
One of the things, Tim, if you don't mind me adding this in, as Dr. Barton's talking, I'm actually looking at our dashboard that we have to track these mental health related calls. And in our CAD and RMS, we're able to label them, right? Like when they come in. So whether it is a 5150 call, a suicide attempt, a commitment for a psych evaluation, we have these different, categories that they get labeled in. We can also add additional labels as to the type of response. And the thing that kind of struck me is, these individuals we consistently and constantly have to serve them in different ways. Maybe there's lower levels of, mental health concerns that they may display. The officers are getting called out to the field. EMS is getting called. A3 is getting called. But we're able to quickly draw in and find what's the best solution for this individual. And instead of using an Excel spreadsheet, we actually have the tiles and graphical representation of the calls, but also we can drill down at a map level, identify, who is this individual. Then we can look at the call details. We can look at who called in, what time of day, who is the officer that responded. We can go back in and look at the body-worn camera footage if we need to, and find out who has the best connection, who has the best rapport. And on those individuals where it isn't a one-off or something that happens maybe once or twice a year. If this is a person who's spiking in our system, it triggers us to be able to do some additional follow-up, right? So try to identify and get this person into services, get them the help that they need prior to being in a crisis.
Yeah, we have the same thing. The challenge is law enforcement in that environment has all that information, and there's no way to crosswalk it into the human service providers, especially in a city this populous. We've got all sorts of teams outside of the public sector teams who are doing great work and collecting information. And so my husband is career law enforcement, and I heard him describe it as it's as though somebody has cancer, and every time they go in, there's a new doctor and there's no treatment history at all. And so it's just inhumane by design.
I'm curious, actually, I'm going to share this question that just came in from one of our listeners, Chris Carlson, because I think we've talked about a few things here. One, we've talked about the need for overcoming these barriers by showing up, seeing each other, getting to know each other. Second, we've talked about some technology solutions, including Peregrine, other ways in which we can solve this from technology. One question that Chris asked is is there, are there legislative changes needed at either the state or federal level that would make this easier? You all, actually all three of you work in different states, so there may be kind of state level or federal changes that would better enable this kind of collaboration and sharing.
Yeah, one of the simple pieces of legislation I'll bring forward this year is that the care responders need the public disclosure exemption, the same as police and fire and EMS have. And so when you set up these new crisis teams or sometimes the co-responder clinicians, they just do not have the same protections, the same legal liability considerations, the same well-being strategies and supports. And so it's really important legislatively that we acknowledge the crisis responders as first responders and think in the same terms. I often say to legislators, whatever police and fire need, we need that in care. And again, I extend that to all the co-responder units. We've got co-response in 14 counties in Washington state.
Interesting.
And
True.
I think there is some legislative, but it does feel very state to state in the moment. But I will say, like, even here in Portland, like, there was just more leadership buy-in from our Medicaid population and our homeless services division in our city to like figure out how can we share that basic information, and so there is some just like buy-in from the leaders to like talk. And what we're trying to do in our lens is like, this is cost savings. What we want to do is capture some of those cost savings and reinvest it in these services that we know work, because this is really a funding decision, right? Like, we know that that's where this is, that's by design, and we get it. So our call is to show that we are super effective in helping get the right services to the right people, which will be cost savings. When we build systems that people want to engage in, they'll run to it and they'll love it and they'll flourish in it. That's what we have to like recognize. So it is getting some political momentum like in that realm of where we're going. And that's why it's so important to have that shared data to just get on the story. And what we sort of tried to agree on is like, let's not point the fingers at each other. It's not a you versus them. It's an us problem. And that's the approach we have to take, because we have a Portland problem. We have these are our folks. So how do we show up together? And that starts with us humanizing each other. But and so that goes like, I'm sure there's legislation, but I'm much more like, this is where it's going to start. And I'm just grateful that we have the right leadership, and our policy folks are like leaning into like, yep, that is the work we're doing, because the acuity is getting so high. We all are noticing it, and we're all struggling with it. So that's hopeful, but also real, in the moment.
Yeah. Well, I mean, what I'm hearing you say there, Drew, is that, as much as, maybe legislative changes might help here or there, but it does come down to leadership, and that it's actually in the hands of locals, which I think I would think is empowering. If you have the right people around the table, you don't need to go necessarily get a law change to get out of the blocks. Yeah, Captain Nakayama, anything to add on that? Any?
No, in California, I believe it is in 2023, there were some legislative changes for care courts and to really introduce mental health concepts and to get individuals that need support into services. It's a funding issue, right? So it's a funding issue at the county level. It's a funding issue at the state level. It's a funding issue even within our court system, in order to have the courts, to have the staff to be able to hear these cases. So I don't want to kind of more on the political legislative side of things, try to stick to law enforcement. But to Drew's point, there's funding gaps, and those are some of the challenges that I've heard working with our county partners. Is it really does come down to a funding issue, and to kind of piggyback on listening to having leadership that's active and involved, but also willing to work and partner to hear those challenges and to meet in the middle. I think that's important, critical.
Can I wanted to, if I can just jump in, I always want to say, like, to me, like, the business case, some of this is being smart at the business case to like get the buy-in, right? The human side, the business side. Like, I always say, like, there's really only two places anyone that's houseless can be fired, like, or can't be fired from. It's our jails, our officers, like, they need to respond, and it's our EDs. So we have to bring those to the table as well. So we in Portland, like, had to bring in our hospital systems and our ERs, because we're trying to also offload some of their things so that they can focus on the heart attack and all that. So it really is a total community response. And I came to this work after being 12 years in our ER here doing street outreach for our folks with high utilization. So that's an easy switch for me. But I think that's where we have to find your champions in your community to figure out who's going to sit with me, who's going to stand alongside me and say, don't just give to Drew, give to us, and we are the experts. We know we can build this system. Please let us shine and do that work together when we're committed to doing that. So that's also like that. I have to trust the other leaders to do that. So that's where some of my trauma comes in of like, oh, I just need to build my teams. No, I just want to build teams. I actually just want people to get the care they are asking for when they're asking for it. And when we can do that, then I'd love to be out of a job. I'd love to not need to do street outreach. Like, that's my goal. If I'm working towards that, lovely. I just want people to get the care they're asking for.
Yeah. Yeah. So this to me relates to something, Drew, you raised earlier, and we talked about in preparation for today, which is this question of, how do we measure success? And I'm curious, Captain Nakayama, you mentioned some of the success metrics you all have seen. Drew, you mentioned some of those. Amy, I know you think about this a lot. I'm curious in particular if you guys could share on, what are the ways of measuring success that, I think first and foremost, it sounds like we want to measure success because we care about the people. But I think, Drew, in addition, like, how do we measure success such that it allows us to make the business case? Like, what are the success metrics that allow us to turn around and make the case, Captain Nakayama, to get the funding, to get the community buy-in? So maybe Dr. Barton, you can kick us off on that of like how you connect the, like, what we need to be measuring on the success front to like how we go make the business case to go out and do this in bigger and better ways.
Yeah, the common metrics in my line of work are 911 response times. So again, if I'm building out diversified response units, can I get law enforcement to those priority 1 calls faster? Right now, it's still 10, 11 minutes. It should be 7 or under, and we haven't achieved that. I don't even know in my lifetime if Seattle's done that. So that's one thing, right? If we can just be more expedient, but we should be looking at jail bookings and hospital stays. We should be looking at recidivism. Washington State sort of decriminalized everything and stopped making arrests and then said, oh, recidivism's better. No, it's not. No, it's not. We're just classifying behaviors in different ways. What I would like to see is that call volume to 911 go down. I'm watching the 988 call volume, right? Is that going up? Because ultimately we want to intervene early. And so I would suggest that in the whole country, as it relates to crime and homeless response, we wait until people are in just deplorable circumstances, so far gone. And then you qualify for therapeutic court, right? Rather than saying no at a misdemeanor level or at the first signs of real vulnerability, somebody is couch surfing. That's when we should intervene. Then it would save the budget at every level of government. It really would. I often talk about in Seattle alone, not even the county, Seattle, we spend about $1 billion a year on first response, on that triage. And then people bemoan, well, treatment's expensive. Is it? Compared to what I'm spending, just sort of triaging folks in first response. And so I appreciate what Drew's saying. I've gotten pretty good at the business case. I can point to exactly what it cost me to send this unit. Right now, we've got buprenorphine in the hands of fire and EMS. And it's the most hopeful thing I've seen because they're starting to do the fire department pop-ups. And I was at our center yesterday, our post-overdose center. 70 people have walked in saying, I'm ready to change. Can you get me on this long-lasting injectable? Then they figured out the Medicaid reimbursement model. And so that is so powerful, again, to just get the word out that, of course, people want help. They don't want to die. They're losing friends to this drug, but we're making it really hard to get treatment. And it's really, really easy and cheap to get high.
Yeah, and on the data side, just to talk a little bit about that, Tim, I think stories are important. Data is important. I think stories get people interested, and then people make decisions with data. And I think you have to have a balance of both. One of the things that we're really proud of is having the stories. So we have the actual stories from the streets, from the officers, from the clinicians that we're partnering with here in the county. But we also have the data to support that the program, that the A3 program through Contra Costa, it is effective. So over a period of time, over several years, we've consistently tracked our calls for service in our CAD system. We've been able to take that information and make it meaningful in bar graphs, in tiles, in mapping. Through Peregrine, we've been able to show a 26% reduction in the number of 5150 or mental health holds from 2023 to 2024. We've also had an overall 41% decrease in mental health related calls that our officers have to go to. and that's a huge time savings for our department. So when we're talking to our local electeds, whether it's at the county level or at the local level within our city government, we have the metrics to show them that the program is effective, that we're utilizing it. And then the other piece of it is we have the stories. And if I can just bore you with a story from the other day. I'm driving to work on a Friday. On Fridays, we have a patrol team that's working. They do great work. We have some additional officers sometimes on Fridays working in our traffic unit, but this day we didn't. And patrol was stacked on calls. They were working 3 or 4 different calls at a time. We had no units available. A call came in, and through our diversion process, our 911 call center received the call. They had the sergeant screen the call with, is this an emergency public safety matter? Is it a crime issue? Or is this something that we can call divert over to our A3 team? Just like we would with a medical related call, they transfer that call to the A3 call center. They do a warm handoff on that call, monitor to make sure that there isn't some sort of additional information that was missed, and then they can divert. That individual who called, that family member, they needed services, and we were able to get them the services through the 911 call system on a diversion basis to A3. That's a success. The officers were doing police officer things. Mental health clinicians were doing mental health clinician things. And I think that's a great story to share, but to have that data to go along with it, to show the effectiveness, and these are real things that are happening, real things that are changing, I think that's huge.
I love that point, Captain Nakayama, of just like the importance of stories and data together. Like we need both sides of the puzzle. We need to appeal to the brain. We need to appeal to the heart to get things done. Thank you for sharing that story. Drew, I'd love to hear your,
I think, I talk about claims data because that's where the money really is, but I just wanted to I just want to add, I think that feedback loop as you're building these systems is critical, not only to your funders, but to your team to get buy-in. So I quickly learned it's really important for me as the social worker to go back to the ER or whatever it is. Hey, John got housed, and celebrate with them and honor and have a team culture to celebrate those successes, as well as to grieve when somebody passes away, to recognize we, despite our best efforts, we do that. So we've tried to create a team and a community culture where we can just lean into that and just celebrate with each other. So really making sure that we have that feedback loop of what happened with it. That's how we get the buy-in. I think that's where we started. That's why people called me oh, I know he'll show up or he'll tell the story. We really built that trust. And then you find those other ways that we can find the shared data to tell the story. And I'll just be honest, I think the number one metrics we can do is people aren't dying on the street, whether it's from suicide or overdose. That's the minimum we all as a community can settle with. Let's start to improve that. That should be our barometer. And how many people are born, how many babies are born in the street. Those are the 2 things I'm can we just get those to as close to zero as we can? If not, how do we do that? Let's start on those ends of things. And I think that's a thing that I don't talk to anyone that's yeah, those are good things to work on. That's something we as a community want to uphold.
Yeah, absolutely. I think, no question, we can all get behind that. So, to folks in the audience, we're about to wrap up here. I got one more question for the panel. If you have any final questions, please submit them. And we've got a few minutes for final questions. If you have one, we'd love to hear from you. But I'd love to hear, from each of you, where do we go from here? What's giving you, hope, excitement on the horizon of your work in this realm? And I'll allow you to popcorn, whoever wants to jump in first.
All right, I'll jump in and say, where do we go from here? I think wherever you are is so rad of where you are. And then think about what are your next steps? Just start to talk. Even you just attending this meeting, I just appreciate you and know you're not alone and trying to think through how do we build a better system. So it's about really making those connections. And then it's harnessing from the get-go to let's just try to make some small improvements, set goals realistically. Don't let good be your enemy. We don't have to be perfect. But let's start to do this. Let's create systems that are nimble and can really adjust there. And I think as you just start to build on those success, if you do it right, if you celebrate, John hasn't called the 911 in 5 days. Holy cow, that's a really big deal if he called 20 times. Just lean into that's progress for everyone. That's super rad. And then we kind of go from there. So I always find such hope but now's also the time to like lean in. Like we can't let all, like stress and anger and all this like overwhelmness, like we as the system need to show up for our folks, so we can do that when we kind of come together. So that's my solution, is if you don't know your local folks, get to know them. If you're in Portland, come find me, I'll go on the streets with you. That's what I'm doing later on today. Like that's how we'll learn from each other, and then listen to our participants. Honestly, most of what I've designed is because I've heard over the years, like they told me what worked. I was just brave enough to listen and say, cool, let's figure out how to get you not into a shelter, but into a tiny home or whatever it is. But if we listen to what they're asking, we'll create systems that actually they're telling us that will work for them.
Thank you, Drew.
And just my perspective on the matter, I think starting and communicating. So even if it's something small, whether it's at an officer level, seeking out, educating yourself, looking for different resources, whether it's in the nonprofit sector, other government services, start somewhere, communicate, build those partnerships and relationships. Those partnerships and relationships have helped us within our county get to where we are today. So start, communicate, and build partnerships.
Awesome. Dr. Barton, last word.
Last word. Well, I am optimistic. These conversations make me optimistic. I feel like all around the country, there's a groundswell, there's a movement that is actually anchored in compassion. I think collectively we're learning how to suspend the judgment and just figure out what is needed here, how can we help? And I think we're becoming more sophisticated, understanding that compassion does not mean an absence of accountability, that we all need accountability, that there has to be cause and effect in order to change. And so I believe everything will change when we depoliticize the conversation. Like, just don't even think in those terms, but rather look at every person, think, okay, if this is my person, if I love the person, if it was my kid, it was me, it was my mom, what would I do? How would I go about this? I think that's such a simple lens, but generally when we look at it that way, we all agree, right? Across ideologies and across backgrounds. So yeah, thank you for the opportunity. It's really fun to be here.
Thank you. Thank you all. I mean, just to kind of recap, a few things that I'm going to walk away from here with is, I was scribbling notes and quotes from you all as we went, because there's some great lines you all shared. I mean, I think, to start, I heard, at the beginning we kicked off with, how we're failing people by design and some of the structural challenges there. But, and Captain Nakayama, I love the way you also framed it, and the people on this call and the people that are in this work are failing forward, are trying new things, are innovating, are getting in the room, are figuring out how we get better, and we are getting better. I think Captain Nakayama, you were talking about the holistic responsibility of policing. Drew, I heard you talking about, finding that shared ground and the importance of getting around a table and actually seeing and knowing each other, and how much of this is human. We can draw your org chart different ways. We can move the boxes around. We can figure out the data, but we got to know each other. We got to get around a table and know and see each other, and a lot's solved through those human connections. And right alongside that, the integration of data is critical. Having that information at your fingertips is critical. So figuring out those more technical, those more data-driven solutions for the operators, as well as to be able to go get the funding you need. And I love this kind of this requisite of stories and data. We need to be able to move the heart and the head. We need those two together. And I think clearly you all have made the business case today. Clearly to me, and both to my head and my heart. So I appreciate, all three of you, the work you do every day and what you've shared with us here today. And I think, again, we at Peregrine just feel privileged to get to be a part of this conversation and get to be working with you all. So thank you for your time. Thank you for everyone in the audience for joining us today. Thank you for the work you're doing every day for the people, for our neighbors. We look forward to, further being a part of the conversation. If you have questions, if you have ideas, you want to be part, please reach out to us. And Civic Roundtable, we're here for it. And again, thank you to our panelists, and have a wonderful rest of your day. Yeah.